I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we're talking about one of the most frequent presentations to the gynaecology clinic, post-menopausal bleeding. Post-menopausal bleeding refers to any vaginal bleeding that occurs in a menopausal woman, and by that, we mean in a woman who has had more than 12 months since her final menstrual period.
Now, postmenopausal bleeding is surprisingly common, occurring in about 10% of postmenopausal patients. Despite being this common, it's a huge cause of concern for many women. Think about it. You've gone through menopause, you're finally done with periods, and you've gotten rid of all of your pads and tampons. And then bam, you start bleeding again. Naturally, every woman immediately assumes it's cancer. But is it always?
Endometrial cancer is definitely something that we look for, and it's the main reason why we investigate postmenopausal bleeding so quickly. In fact, vaginal bleeding is the presenting sign in more than 90% of postmenopausal women with endometrial cancer. Despite this, endometrial cancer is one of the least common causes of postmenopausal bleeding, occurring in less than 10% of patients. In the majority of cases, postmenopausal bleeding is due to atrophy or polyps. Common causes of postmenopausal bleeding include polyps, atrophy, infection, proliferative or secretory endometrium, which is usually due to a random hormonal surge, cancer, fibroids, and endometrial hyperplasia. Let's go into these a little bit more in detail. First, what is a polyp?
Polyps are technically localized hyperplastic overgrowths of glandular tissue, although this is a bit of a mouthful. When I'm explaining polyps to patients, I usually just describe them as little skin tags. Polyps can occur in the uterus, on the cervix, or even from the vaginal walls, and treating them is actually really easy. We typically just remove them. Almost always, polyps are benign, but very occasionally they might be malignant, and so whenever we remove a polyp, we always send it to the lab for analysis, just in case.
Atrophy is another really common cause of postmenopausal bleeding and is mainly due to a lack of estrogen. After a woman goes through menopause, the production of estrogen from her ovaries stops. This causes really thin vulvovaginal and uterine tissue, which can become inflamed and erode really easily. Atrophy typically causes light bleeding or spotting. Women with atrophy might also describe vaginal dryness and discomfort, but they are often asymptomatic. The treatment again is very straightforward, and we usually prescribe topical estrogen like Avestin or Vagifem.
What about fibroids?
Fibroids are a tricky one. In general, fibroids are really common, with about 80% of premenopausal women having them. And in this population, they are a really common cause of abnormal uterine bleeding. After menopause, the prevalence and size of fibroids decreases dramatically. This is because fibroid growth is triggered by hormones, and with menopause, the production of hormones stops, and thus the fibroids shrink. It's really, really uncommon for a fibroid to be the cause of bleeding in a postmenopausal patient. So, if you have a woman with postmenopausal bleeding and a fibroid on the ultrasound, you should always look for other causes, and not just automatically assume that the bleeding is from the fibroid. As with every fibroid, there is a small chance of leiomyosarcoma, so if a woman does have a fibroid that is increasing in size or producing symptoms like pelvic pain or pressure, then that would definitely require further consideration.
What about adenomyosis?
Adenomyosis is again another common cause of premenopausal abnormal bleeding, but is much less common in the postmenopausal patient. Even though the ultrasound might suggest features of adenomyosis, it's highly unlikely that this would ever be the cause of postmenopausal bleeding.
Endometrial hyperplasia is another cause of postmenopausal bleeding. This is basically an overgrowth of the lining of the womb and can be considered to be a pre-malignant condition. Treatment options include surveillance, progesterone, or hysterectomy. We'll go into endometrial hyperplasia in a bit more detail in our next episode.
And our final consideration is, of course, malignancy. The most common malignant cause of postmenopausal bleeding is endometrial cancer. The good thing about endometrial cancer is that it typically lets you know that it's there by causing abnormal vaginal bleeding. In most cases, the cancer is picked up early and can be treated easily. Other malignancies include choriocarcinoma. Remember from our GTN episode that choriocarcinoma can even occur in postmenopausal patients. Cervical cancer or vaginal cancer may also cause abnormal postmenopausal bleeding, and so it's important to think about sources of bleeding other than the uterus.
There are a few less common causes of postmenopausal bleeding, which include genital tuberculosis, post-radiation changes, or endometritis. Certain anticoagulants or antiplatelet medications can also contribute to an increased risk of uterine bleeding. We also need to consider disease by nearby organs. For example, inflammation from diverticulitis may cause adjacent inflammation in the pelvic organs. There may also be fistulae, or the bleeding may actually be from another orifice. It may be rectal bleeding.
That's a really important point. One of the first things we need to do is work out whether the bleeding is actually coming from the uterus or not. This can be done through a careful history and examination. If in doubt, you could always ask the woman to insert a tampon. If she has bleeding but the tampon comes out clean, then you know the bleeding is not from the uterus or vagina. Sometimes bleeding may also be coming from the lower genital tract rather than the uterus. An example of this would be ulceration from a pessary, or vaginal trauma or tearing from intercourse, or even a foreign body. This could be easily detected on a speculum examination.
Okay, so there are clearly quite a few things that could be going on when a woman presents with postmenopausal bleeding. Diagnosing or excluding cancer is obviously our main objective, but how do we work out whether it's one of the other causes? What should our approach be when managing a patient who presents with postmenopausal bleeding?
Well, let's do this the best way we know, through a case. Let's meet Barbara. Barbara is a 55-year-old who was referred by her GP for postmenopausal bleeding. What kind of questions would you ask in a history?
Well, the first thing I would want to know is about the bleeding itself. How much has she been bleeding? How long does she bleed for? And when did it start? I'd then want to ask questions specifically relating to my differential diagnosis. Does she have any features of atrophy, such as vaginal dryness and soreness with intercourse? Is her cervical screening up to date, and has she had any previous STIs? Importantly, we want to know when her last CST was and if she has ever had any abnormal CSTs. Hopefully the GP has sent a recent CST co-test and sent it in with her referral. Were there any precipitating factors like trauma, intercourse, or foreign body insertion? It's always important to consider the possibility that the bleeding may be vaginal and explore the possibility of sexual assault or intimate partner violence, which is unfortunately common in postmenopausal and vulnerable populations, such as those living in a nursing home. From a gynaecological perspective, we should gather an obstetric history, particularly because nulliparity is associated with an increased risk of endometrial cancer. We need to review her medications, including any anticoagulants, herbal supplements, and tamoxifen. It is crucial to ask if she is or has ever been on hormone replacement therapy, especially unopposed estrogen. Unopposed estrogen and tamoxifen are both associated with an increased risk of endometrial cancer. Understanding her past medical and surgical history, including diabetes, obesity, and breast cancer, helps to assess the patient's risk factors for endometrial cancer. And finally, it's important to note a family history of breast, colon, or endometrial cancer, which may suggest an underlying genetic condition called Lynch syndrome, which also increases the risk of endometrial cancer.
So basically, we're taking a screening history of the bleeding and then taking a full medical history, paying particular attention to any risk factors for endometrial cancer. Just to recap, what are the risk factors for endometrial cancer we might be looking for?
The risk factors for endometrial cancer basically include any condition that increases exposure to estrogen. For example, obesity, diabetes, PCOS, use of unopposed estrogen, nulliparity, tamoxifen use, early menarche, and late menopause. We also need to consider genetic causes like Lynch or Cowden syndrome and a family history of breast, colon, or endometrial cancer.
So for our patient Barbara, her last period was about 4 years ago. She's had a couple of episodes of vaginal bleeding in the last month, once on wiping and once there was a small amount of fresh blood on her underwear. There is no history of dryness or possible vaginal trauma, and she is not taking any anticoagulant medications. Barbara does take continuous combined menopausal hormonal therapy for her hot flashes. She is nulliparous and has a history of diabetes and obesity. Her routine screening CST was 3 years ago and was normal. She has no significant family history.
So we can see that Barbara has a few risk factors here, mainly her nulliparity, diabetes, and obesity. So let's move on to our examination. What should we be assessing for during the physical exam?
Apart from confirming the BMI, the main goal of the physical examination is to assess the genital tract. Check the vulva for lesions, tears, or varicose veins which may be the source of the bleeding. A speculum examination allows assessment of the vaginal walls and cervix for abnormalities like tears, polyps, atrophy, foreign bodies, or malignancy. If the patient can tolerate it, a bimanual examination can also be helpful to assess the size of the uterus and any masses. You should also palpate for any abdominal distension or enlarged lymph nodes. A rectal examination could be considered if there is any suggestion of rectal bleeding, but is not typically routine.
Okay, so Barbara has a normal external genital examination. Her vagina is pale with loss of rugo suggesting signs of vulvovaginal atrophy. Her cervix has a normal appearance with no obvious lesions or polyps, and a bimanual examination reveals a small anteverted mobile uterus. Our next step is investigations. What investigations would you order for a patient with postmenopausal bleeding?
The typical workup for postmenopausal bleeding would include a CST COAST test, pelvic ultrasound, and an endometrial biopsy. You could also consider a full blood count, a TSH, coagulation studies, and vaginal swabs if you're worried about anemia or other causes of abnormal bleeding. Cervical screening tests are essential to exclude lower genital tract causes of bleeding, although we should really be doing a co-test. A co-test includes HPV testing and liquid-based cytology and should always be done when investigating abnormal symptoms. A self-collected CST is not appropriate in this setting. For our patient Barbara, she had a normal CST 3 years ago. When we're doing our speculum exam, I would perform a repeat CST co-test. Now, ACOG recommends that either endometrial sampling or a transvaginal ultrasound can be used as the first diagnostic step for evaluating the endometrium. In Australia, most patients with postmenopausal bleeding see their GP first, and so our typical first-line investigation would be a pelvic ultrasound.
Great! Fortunately, Barbara has already had a transvaginal ultrasound, and she comes to you with the report in hand. It reads, normal anteverted small volume uterus. Both ovaries are normal and there is no free fluid in the pouch of Douglas. The endometrial thickness is 7 millimeters. How is this information helpful?
The role of the pelvic ultrasound is to measure the endometrial thickness to help us to identify which patients are at increased risk of endometrial cancer. It can also identify conditions like polyps, fibroids, or ovarian masses. Now, the magic number to remember in postmenopausal patients is an endometrial thickness of 4 millimeters. In asymptomatic women, an endometrial thickness of 4 millimeters or less has a greater than 99% negative predictive value for endometrial cancer. This means that these patients are highly unlikely to have cancer and can be reassured without a biopsy. In fact, the chance of having endometrial cancer with an endometrial stripe thickness of less than or equal to 4 millimeters is about 0.3%. Now, if a woman has risk factors for malignancy, is over 60, or has persistent or recurrent bleeding, she should undergo endometrial sampling regardless of the endometrial thickness on ultrasound. About 1 in 339 endometrial cancers are missed using a biopsy threshold of over 4 millimeters, and so by investigating these higher risk patients, we hope to pick up those cancers. In women with an endometrial thickness of more than 4 millimeters, the prevalence of endometrial cancer is more frequent, and so an endometrial biopsy is required.
So, who came up with this cutoff of more than 4 millimeters? And how reliable is this in detecting endometrial cancer?
There have actually been quite a few multi-centre trials and retrospective analyses which have quite clearly established 4 millimeters as the threshold above which endometrial sampling should be considered. A meta-analysis by Smith-Bindman et al. Of nearly 6,000 women found that using a 5 millimeter cutoff to define abnormally thick endometrium was 96% sensitive for detecting endometrial cancer and 92% sensitive for detecting any endometrial disease.
Are there any other features that you might make you consider further investigation, even if the endometrial thickness is under 4 millimeters?
There are a few risk factors that might increase the risk of endometrial hyperplasia or cancer and would warrant further testing with biopsy and/or hysteroscopy. These include when the endometrium isn't adequately visualized or has an irregular outline, the presence of cystic spaces in the endometrium or fluid in the endometrial cavity, the presence of a focal lesion like a polyp or focal heterogeneous area, risk factors for endometrial cancer like obesity, age over 60, PCOS, diabetes, unopposed estrogen use, a family history of cancer, or a CST demonstrating atypical glandular cells, and of course, if bleeding persists despite an endometrial thickness of less than 4 millimeters.
So Barbara has an endometrial thickness of 7 millimeters, which automatically places her in a high-risk category and means she meets criteria for a biopsy. Now, even if Barbara had an endometrial thickness of 3 millimeters, she would probably still warrant a biopsy given her history of diabetes and obesity, which are both risk factors for endometrial cancer. How would you counsel Barbara, and what kind of biopsy would you perform?
I would start by giving Barbara a little bit of information. I'd explain that postmenopausal bleeding is a really common presentation, and that most of the time the bleeding is due to something benign, like a polyp or atrophy. Sometimes postmenopausal bleeding can occur due to endometrial cancer, and so in any woman with postmenopausal bleeding and an increased endometrial thickness, we would recommend an endometrial biopsy to exclude this. I would reassure her that this is pretty uncommon, but if there is any chance of cancer, then we want to act quickly, which is why we get these patients in through the outpatient department quite quickly. I often find that women are quite alarmed when they're told they have a Category 1 appointment and immediately assume the worst. So it can be good to put this into a little bit of perspective.
Now, there are two main ways of obtaining an endometrial biopsy: through Papel sampling or hysteroscopy dilatation and curettage. Endometrial sampling provides tissue for histological diagnosis, which is critical in identifying malignancies.
The Papel biopsy is a commonly used method due to its minimal invasiveness and high accuracy. It's essentially an office biopsy that doesn't usually require cervical dilatation or anesthesia and is a quick procedure with a low risk of uterine perforation. I describe it to patients as a very tiny straw that is passed through the cervix to take a small biopsy of the lining cells of the womb. I do explain that it usually causes abdominal cramping, and some women find it very uncomfortable. Most women tolerate it easily and are happy to attempt it because the results are quick, which means they can get the diagnosis sooner, and they could potentially avoid an anaesthetic. The benefit of a Papel is that if it does detect endometrial cancer, then you can get the woman on the right treatment pathway a lot sooner than if she waits for a D&C. The alternative is a hysteroscopy D&C. This can be done under local or regional anaesthetic, sedation, or general anaesthesia. It involves passing a small camera through the cervical os to visualize the uterine cavity. Small metal dilators are then used to dilate the cervix, and a curette is used to sample the endometrium. Some centres do outpatient hysteroscopies, which are usually combined with the Papel.
So are they much of a muchness, or are there times where a D&C might be better than a Papel?
Both are acceptable ways for obtaining an endometrial biopsy, but there are some differences between them. A Papel is quick and easy to do in the office with minimal or no cervical dilatation. It doesn't require any anaesthetic, and the results are generally back faster than with a D&C. It's also cheaper and safer with a much lower risk of uterine perforation than a D&C. The downsides of a Papel are that it can be uncomfortable in 10% of women, there's a high chance of an inadequate specimen, and it only samples 50% of the endometrium. This sounds alarming at first, but despite this, there is actually an excellent correlation between the histopathology of endometrial specimens taken by Papel and D&C. The sensitivity for the diagnosis of endometrial carcinoma with a Papel in a postmenopausal patient is 99.6% with a specificity of greater than 98%. The sensitivity of a Papel for the detection of endometrial hyperplasia is slightly lower at 81%, although these patients will likely have ongoing bleeding and require HD&C anyway, thereby reducing the amount of missed cases. There are also times when the patient agrees to a Papel sample, but you can't actually perform it, for instance due to cervical stenosis or patient discomfort. Papel sampling also has about an 8 to 30% failure rate, which includes failure to obtain a sample and inadequate sample, with these patients then needing to go on and have a HD&C.
A hysteroscopy has the advantage of allowing direct visualization of the uterine cavity, targeted biopsies, and excision of polyps. This is particularly useful in patients with a focal endometrial lesion or a suspected endometrial polyp. A HD&C may be preferred for all patients with focal lesions on ultrasounds when a Papel can't be performed, for example due to cervical stenosis or patient discomfort, after a non-diagnostic Papel result, if bleeding persists despite a normal Papel, or if the patient is having another procedure anyway, like a laparoscopy for example. Or if the Papel suggests endometrial hyperplasia. Remember, Papels only sample 50% of the endometrium, so if you have a Papel demonstrating endometrial hyperplasia, then you need to get a more thorough sample to exclude the coexistence of endometrial cancer.
Okay, so we counsel Barbara on the recommendation for endometrial sampling, and she agrees to try an endometrial Papel. Unfortunately, her cervix is quite stenosed, and so we book her up for a hysteroscopy D&C. When preparing for the D&C, do we need to chart misoprostol for cervical priming?
To misoprostol or not misoprostol? That is the question. Now, there is quite a bit of variation in practice about whether to prescribe misoprostol or not for postmenopausal patients undergoing D&C. The idea is that misoprostol softens and opens the cervix, allowing less need for dilatation, a faster and easier procedure, and less chance of uterine perforation. In postmenopausal patients, especially those in whom a propel has failed due to a stenosed cervix, you might be tempted to chart misoprostol. But actually, the evidence for misoprostol in cervical priming for postmenopausal patients says no. A 2018 meta-analysis by Nakano et al. Showed the misoprostol did not reduce pain intensity, the duration of the procedure, or the need for additional cervical dilatation. But it did increase the risk of adverse side effects like abdominal discomfort, diarrhea, nausea, and fever. The conclusion from this review was that misoprostol should not be charted for postmenopausal patients undergoing HD&C. Now, there is one RCT from 2010 that suggests that if the patient is pre-treated with 25 micrograms of vaginal estradiol tablets for 14 days and then administered 1,000 micrograms of vaginal misoprostol 12 hours before the D&C, then there may be some benefit in cervical ripening. And this is also supported by the ACOG guidelines. So if you are thinking of using misoprostol, then consider estradiol pre-treatment first.
Okay, so no to misoprostol. Now, Barbara tells you that her friend had a D&C recently in the clinic, and she wonders whether this might be an option for her, since she would really prefer to not have a general anaesthetic. Is that an option?
Outpatient hysteroscopy is certainly an option for Barbara if it's offered to her by her local hospital. Outpatient hysteroscopy is typically performed in the clinic or sometimes on a minor operating list using only Penzrax and local anaesthetic. It's typically well tolerated by women and has many benefits for both women and the hospital service. For the woman, it's more convenient with easier scheduling and less downtime. There's less exposure to general anaesthetic, no need to fast, faster return to normal activities, and it's generally a preferred option for patients. For hospitals, it's cost-effective and utilises less hospital resources. The issue for Barbara is whether that option is available at her local hospital.
Outpatient hysteroscopy is becoming increasingly more prevalent in Australia and New Zealand. In Queensland, the Gold Coast University Hospital and Townsville Hospital are currently the only hospitals offering outpatient hysteroscopy. SCU and QE2 are also looking at following suit, and in fact, the SCU outpatient hysteroscopy service is due to commence over the next few months. The Mercy Hospital in Melbourne boasts Australia's longest running and most successful outpatient hysteroscopy department, and occasionally runs workshops to help other hospitals to set up their own outpatient hysteroscopy service. So if your hospital is interested in setting this up, then get in contact with the nearest hospital that offers this service. If Barbara's hospital does not offer outpatient hysteroscopy, but she still doesn't want a GA, then it is also possible to perform the procedure in the operating theatre under alternative anaesthetic, like a spinal, sedation, or even simply local anaesthetic.
So fortunately, Barbara is being seen at the Gold Coast University Hospital, where outpatient hysteroscopy has really taken off. She has an uncomplicated procedure which identified an endometrial polyp that is removed with a MyoSure device. Barbara recovers well and goes home the same day. Her histopathology demonstrates a benign endometrial polyp and she has no further bleeding. So that wraps up Barbara's experience with the gynaecology service. Let's do a quick summary of what we've covered.
Summary time. Postmenopausal bleeding occurs in 10% of postmenopausal women. 90% of women with endometrial cancer will present with postmenopausal bleeding. But only about 6% of women with postmenopausal bleeding will actually have endometrial cancer. Other common causes of postmenopausal bleeding include atrophy, polyps, fibroids, endometrial hyperplasia or endometrial cancer, cervical infection, cervical cancer or a cervical polyp, and vaginal trauma or cancer or laceration, and being on anticoagulants.
The workup of postmenopausal bleeding includes a thorough history specifically looking for risk factors for endometrial cancer. These include age over 60, obesity, PCOS, diabetes, unopposed estrogen use, nulliparity, early menarche and late menopause, tamoxifen use, a CST showing atypical endocervical cells, Lynch or Cowden syndrome, and a family history of breast, bowel, or uterine cancer. Examination should include BMI, abdominal exam, speculum, and bimanual, and you could consider a rectal exam.
Investigations should include a CST co-test, a pelvic ultrasound, and endometrial biopsy. Full blood count, high vaginal swabs, STI screen, and coagulation profile may be performed if indicated. In the absence of risk factors, a one-off episode of postmenopausal bleeding with an endometrial thickness of less than 4 millimeters has a less than 1% chance of endometrial cancer and does not require a biopsy. Women who do require a biopsy include women with a postmenopausal bleeding and an endometrial thickness over 4 millimeters, recurrent or persistent postmenopausal bleeding despite an endometrial thickness of less than 4 millimeters, an endometrial thickness less than 4 millimeters, and risk factors for endometrial cancer, endometrial thickness that is not visualized, a focal endometrial abnormality, fluid in the endometrial cavity, irregular endometrium, or cystic spaces.
Biopsy options include endometrial papille or a HDNC. Endometrial papille is just as sensitive as a HDNC, but it only samples 50% of the endometrium and has a higher failure rate. Hysteroscopy is preferred for insufficient sample, inadequate papille, or an inability to obtain a papille, a focal endometrial lesion, an endometrial papille that shows endometrial hyperplasia, and ongoing bleeding despite a normal papille. Outpatient hysteroscopy is a safe and well-tolerated option for many women. Misoprostol is not recommended for cervical priming in postmenopausal women before a HDNC unless vaginal estrogen has been administered for 2 weeks prior.
Okay, before we wrap up, I've got a few questions that I've been pondering for a while regarding postmenopausal bleeding. Firstly, we mentioned that Barbara was on menopausal hormonal therapy. Should we recommend that patients stop their HRT whilst getting worked up for postmenopausal bleeding?
We get a lot of women referred with abnormal bleeding after commencing menopause hormonal therapy, and it's important to note a few things. Firstly, uterine bleeding occurs in almost all patients receiving combined cyclic hormonal therapy. While uterine bleeding can also occur in the early months of combined continuous hormonal therapy regimens, patients with continued bleeding beyond 6 months require endometrial evaluation. Uninvestigated bleeding is a contraindication to menopausal hormonal therapy, and so for this reason, if bleeding persists beyond 6 months, Barbara should be advised to stop menopausal hormonal therapy until the bleeding has been completely investigated. Remember, unopposed estrogen in someone with an intact uterus is contraindicated. Note, this does not apply to vaginal estrogens.
Next question. So we mentioned that greater than 4 millimeters is a cutoff for a biopsy in asymptomatic women. Does that mean we use a different cutoff for asymptomatic women?
Now, this is a little bit unclear. The incidence of endometrial cancer in asymptomatic women is significantly lower than in women with postmenopausal bleeding, even if the endometrial thickness is over 4 millimeters. For this reason, we tend to use a higher endometrial thickness cutoff for patients who have an incidentally detected thickened endometrium on a scan done for some other reason. A meta-analysis by Smith-Bindman concluded that an endometrial thickness of more than 11 millimeters places an asymptomatic postmenopausal woman at approximately 6.7% risk of cancer, which is similar to the approximate 7.3% risk of cancer in a woman with postmenopausal bleeding and an endometrial thickness measuring 5 millimeters. For years, many facilities have used the 11 millimeter cutoff as a threshold for biopsy in asymptomatic women. ACOG recommends that the decision to evaluate asymptomatic postmenopausal women with thickened endometrial stripe needs to be an individualized, case-by-case decision based on risk factors and patient characteristics, rather than the endometrial cutoff of 4 millimeters used for postmenopausal bleeding patients.
All right. So what if the histopathology returns with proliferative or secretory endometrium?
Well, if you think back to the endometrial changes during a menstrual cycle, proliferative or secretory endometrium suggests the presence of estrogen. You should consider where the estrogen is coming from, whether it's exogenous or could it be an estrogen-secreting tumour.
Good point. And one final question. What about in women who never quite stop bleeding? We're talking about someone well over the average age of menopause who just continues to get periods. When should we investigate here?
In Australia, most women will go through menopause around age 50 to 51. However, that doesn't mean that all women will. In some patients, menopause can occur earlier or even much later. Late onset menopause is defined as menopause after age 55. In general, if a woman continues to have bleeding over the age of 55, she should be considered for an endometrial biopsy to exclude pathology.
A great resource for anyone working in general practice or your average gynaecology clinic is a flowchart available from canceraustralia.com for the workup of abnormal bleeding in the postmenopausal woman.
Also, it's our first birthday this week.
Yay!
Yay! Yippee! We're reaching all of our milestones. So excited to go forward. We just wanted to say thank you to everyone for all of your support so far, and we can't wait to make more episodes for you in our second year of life.
Remember, you'll find our summary slides on our Instagram later in the week. If you have any questions or you want to fact check us, get in touch to our email, theuterinesound@gmail.com, our website, www.theuterinesound.com, or socials @theuterinesound.